Welcome everybody. My name is Brad Meyer. I am the Chief Executive Officer for Bluestem Health. Some of you guys may have known us when we were People's Health Center. In January 18, we changed our name. So I've been there just over 5 years. So I'm the longest serving CEO for the organization. So Bluestem Health is a federally qualified health center. What that means is that we get about $1.5 million a year to provide care for the underserved and uninsured populations. 1.5 sounds like a lot of money, but when you have about a $17 million budget, it's kind of a drop in the bucket. So one of the things that we're tasked to do is provide care for all people regardless of their insurance. And we use that grant money to offset our expenses with our sliding fee discount program. So our sliding fee discount program is a graduated scale. So patients who are below 200% of the federal poverty limits can have access to medical, dental, and behavioral health services at a reduced rate. I don't know the numbers right off the top of my head, so these are all just fictional, but let's say a family of four that makes $21,000 a year, they would qualify at the 100% of the federal poverty limits, which means that any member of the family can come and for $30, they can see a provider, a medical provider, nurse practitioner, physician, and if they need labs, they pay an additional $10 per lab. So your typical diabetic, when they go to the doctor's office, they need, about 2 labs. So that charge would be about $50. That same office visit in a private practice with no insurance could be anywhere between $150 and $200. So the labs for the diabetics, we use that $1.5 million grant money to offset the losses. We have, I'll show a few numbers, but right now we have about 16,000 patients. We spend about $40,000 a month just on providing lab work for those 16,000 patients. When you add on that we spend about $400,000 on interpreter fees, you can see that $1.5 million doesn't last very long. So that's kind of how the sliding fee scale. So the minimal on the medical side is $30, and it goes up to our level 4, which is $70. One of the good things about the sliding fee discount program is it's even good for the insured population. Many of you guys know this, some of you guys may not, but Lincoln has the lowest uninsured numbers in the state. In fact, in Lincoln, we have about 25% of our population is uninsured, which is significantly less than Omaha, Norfolk, even Hastings. And so one of the things that we have been really marketing is if you have insurance, most of the time people who are the working poor they have high deductible plans. So Lincoln has a very high rate of high deductible plans. We work with Smart Chicken, Smithfield, Farmland, because they have $3,000, $5,000 deductibles. We even have patients that have $10,000 and $12,000 deductibles. If you have a family of 4, relatively healthy, even at a $5,000 deductible, you may not, it doesn't matter whether you have insurance or not. You're going to be responsible for that first $5,000. So how that works in our organization is you come, you pay whatever your copay is. We send your insurance a bill, let's say $200. The insurance says, yep, that's fine and dandy, but now it's the patient's responsibility because we're going to apply it towards the deductible. So that patient now owes us $200. So what we do is if we get them on our sliding fee discount program, let's say they're at L4, which is our highest level, we look at their charges and say, okay, all you have to do is pay your copay of $70 and we'll write the rest off. So it's a double benefit to the patient because that $200 went to their deductible, but they only have to pay us $70 for that visit. And so it's a great deal for those that are at 200% or below the federal poverty limits. If you're over 200%, there's really no advantage, and you're uninsured, there's really no advantage to coming to our clinic for medical dental treatments, with one caveat. We have a 340B pharmacy program where patients who are members of our organization can use Walgreens, Kohl's, Walmart, Genoa Pharmacy at our Health 360 clinic, and they can get discounted medications. So excuse me, starting to get a cold, so. So one of the examples I like to use is azithromycin, Z-Pak. If an uninsured person was to get a prescription for Z-Pak, it would be about $65 or $70 out of pocket. They can come through, and if one of our providers writes that prescription, we can get it for about $18. So it's a very steep discount for a lot of the medications that we can get through the 340B pharmacy program. So that is how we use our federally qualified health center status, and that's what we use our grant money for. All right, so we provide medical and dental care, but we also have integrated behavioral health. Everybody says they have integrated behavioral health, but I'll tell you kind of how we do it. So we have 3 licensed independent mental health practitioners. They're all master's prepared in our primary care clinics. And so they don't do your traditional 50-minute therapy sessions. They're there to support the primary care team. And so their job is to meet with patients who, we'll just use, let's say a patient comes in for an earache. They see the medical provider and say, you know, I lost my job last week. I don't know how I'm going to, you know, do anything. I'm just struggling. That's something that the provider would like to deal with, but doesn't have the time. So the provider can go out, grab one of the behavioral health consultants. The BHC can go in and triage the patient. Is the patient in a crisis situation? Are they in a potential crisis? Or do they have good coping skills? They just need additional resources. So then the BHC can pull them out of the room and get them set up with community support, our patient support department, or maybe if they need some therapy, they can provide 3 to 6 episodes of treatment. But if they need long-term treatment, then they refer them out to one of our community partners. We also use them for chronic disease. So if a patient has diabetes, and I'm sure none of your clients have a situation like this. So let's say they have a chronic disease like diabetes, and we just can't get their blood sugars down. In a private practice, if you guys haven't noticed, private practices are, they're getting paid for taking better care of their patients, called value-based purchasing agreements. So if you have a patient who is not getting better, that hurts their scores. And so a physician's gonna say, I've given you the tools to get your diabetes, you're not doing any of it, so you're non-compliant. And some practices will even discharge those patients because they're non-compliant to kind of get them off their books. In our situation, we realize that if a patient is coming to their appointment, they don't want to be non-compliant. And so we can bring that BHC in to decide, and kind of triage them and say, is there a mental health barrier going on here? Maybe they don't understand their disease. Maybe they are having other things going on in their life that they're really not focusing on their disease. So then that BHC can work with our certified diabetic educator. We have a chronic disease nurse. We have Jane over here, who's a certified paramedic. That team can then wrap care around that patient. They'll send Jane out to go do a home visit. Jane can go out there and say, you know, I went out there. She seems to be having good fruits and vegetables, seems to be doing good on the meal plan. And then that tells the provider, okay, maybe it's a medication issue. Let's talk about medication. Or Jane will go out there and say, you know, there's cereal boxes all over. And that tells the provider that it is a diet and exercise situation. So our goal with all of our chronic disease patients is to wrap them around with so many resources that they really have to try to fail. We have so many different things that we do between our diabetic educator, chronic disease nurse, Jane, our patient support system. Pretty much we have resources for pretty much any patient, and using their community partners like you guys, we can find anything for our patients. And that's what we do. We try to go that extra mile. So most of our patients right now are from Lincoln, but they come as far as Grand Island. Even though Grand Island has an FQHC, we have patients from Crete, Seward, but our primary population is Lincoln. Any questions so far? So this is some of our medical team. In 2018, we had 12,389 unduplicated patients between medical, dental, behavioral health. As of last month, we've already hit about 16,000 patients for this year. And so I estimate that by the end of the year, we'll have about 20,000 patients. And we've kind of grown through our acquisition of other private practices. In December of 2016, we took over our first private practice. It was a doctor here in town who had to medically retire. So we put a physician in his clinic to kind of help him out and not displace his patients. Dr. Bick Chow came on in June of 2018. And then our latest acquisition was Dr. Charles Kreschel's office at 14th and Adams. And so Lincoln is becoming a primary care desert. There are so many independent family practice docs retiring in the next 5 years that we're estimating there could be 30 to 40,000 patients being displaced. Right now, we are recruiting, Brian is recruiting, St. E's is recruiting, the independents are recruiting. There's just not enough primary care docs graduating to fill all of the needs in the US, let alone Lincoln. So our goal has kind of been, let's go into these practices where the docs are managing their clinics, let them just focus on being a doctor. We'll take over the management of their clinic, and that will keep them practicing for a few more years while we try to recruit a physician for their office. Luckily, we've been semi-successful. We've been recruiting 3 physicians since September of last year. We just hired one who will be here in June 2020. We have one that is has our employment agreement that is very much considering coming here. And so we think by the end of the year we'll have one other physician signed. And so June and July of 2020 we'll be bringing on 2 additional physicians for sure. We're also making plans to convert our main site in Health 360 to add 2 more advanced practice providers. We have way too many patients trying to get in to see us. And some of you guys may have, your clients may have told you this, but in July, from July to the middle of August, we had to stop seeing patients, new patients. And we're going to have to probably do that again at some point, but we're really struggling and we're really trying hard to see all the patients that can, that want to see us. But we just don't have capacity to see any more patients than what we're currently seeing. So we're going to add space so that we can see more patients. But in the next 5 years, you're going to see a lot of people struggling to find a primary care provider, especially if they're Medicaid and Medicare. We have a large, the number of Medicare patients coming to Lincoln pretty much doubles every year. I think last year we saw a 10% increase in Lincoln from the Medicare population. And primarily that's because the people from smaller towns having more chronic diseases, so they want to move closer to their doctor or move closer to the hospital that is seeing them for their chronic diseases. But once they get here, a lot of the physician practices in Lincoln are not accepting new Medicare patients. They're seeing their patients that have grown old with them, but a lot of them are not seeing Medicare patients that are just coming in right off the street. So we estimate that that's probably going to grow every year by 10% from just the Medicare population alone.
Can I?
Yep.
When you had to stop for understandable reasons seeing new patients, does that put your federally qualified funding at risk?
No. So the federal guidelines say that we have to offer services to the underserved and uninsured population. We are still seeing established, uninsured, and underserved patients. We're just not able to see new patients during that time. But we're still seeing the existing base of patients that are uninsured and underserved populations. So we don't have to accept new patients. We're like a private practice in that regard. In fact, HRSA, the feds, would want us to continue serving the patients that have already come to us. And so the patients that are already coming to us, on average, see their provider between 3 and 3.2 encounters per patient. So in a regular private practice, most patients see their doctor once or twice a year. Our patients see our providers more than 3 times per year. So our goal is to our existing patients. As long as we can continue serving our existing patients, that's our goal and that's our focus. New patients that come in is great, but at some point we just don't have enough providers to see all the new patients that want to come and see us. APPs, Advanced Practice Providers. They're otherwise known as mid-levels, but mid-levels don't like being called mid-levels. So those are nurse practitioners and physician assistants.
Okay.
So the new term is Advanced Practice Providers.
And then how do you pay your practice?
So all of our docs, all of our providers, medical, dental, are employed. So they have a salary.
Okay.
But we have to pay fair market wages. So our providers right now see on average 14 to 16 patients per day. Where in a private practice, they're gonna have to see 20 to 30 patients per day. But because 40% of our population speak a language other than English as their primary language, it takes a little bit longer for our providers to see our patients. And so that's why they're only averaging about 16 patients per day. So in our organization, we have a large mental health population, as well as patients on Medicaid. So out of our 16,000 patients, About 43 to 45% of them are Medicaid. And so Medicaid patients on average do go to the doctor more. They also are the highest utilizers of emergency room visits. And primarily it's because they don't really have to pay for it. So any sniffles, any chronic disease, or anything that they're just wondering about, they're more apt to use physician services than most commercially insured or uninsured patient.
A lot of times.
So there are studies, and I'm not going to quote statistics because I'll be wrong, but states who have not expanded Medicaid have an unhealthier population because you have more working poor that are working longer with chronic disease or mental health disorders because they just don't go to the doctor. At some point, if they are sick enough, they go to the doctor, and then that's when the costs for that patient rise. A person who is diabetic, so I know of cases where a patient comes in and their A1C, which is a blood count to show how much they, how bad their blood sugars are, don't even register because they're so high. Anybody who has had an A1C over 9 or over 11 has had diabetes for a long time. And they've been shown symptoms, they have just been ignoring it. If you have someone who is off the charts with their A1C, the doc is worried about DKA or some other, peripheral damage because that patient just hasn't gotten the treatment. So guess what happens at that appointment? All of a sudden they get an appointment to see an endocrinologist, they get an appointment to get more lab work done, maybe they have to go to the ER. If they have to go to the ER, I can pretty much guarantee you they're gonna put them in the hospital overnight, at least 1 or 2 days, to try to get their body reacting right. They discharge them with a couple days medication. Hopefully that patient comes back to us or fills that medication and uses it. But chances are, if they can't afford the medication before, what are the odds they're going to be able to afford the medication afterwards? So yeah, it's a very big deal that most people don't think about with the uninsured populations, and that's why Medicaid expansion is very important for the working poor, because that's who's going to benefit the most from Medicaid expansion. It's not going to be the people that are already on Medicaid are the ones that really deserve to be on Medicaid. There's a lot of people that are in that 101 to 138% that are the working poor. They can't afford the insurance, and they're probably,
Time off from because they
but
don't get
medically speaking, and that's one of the things that the hospitals are really concerned that once Medicaid expansion happens, they're just going to be inundated in the ER. I don't think that's the case. I think the people that are already utilizing the ER, whether they're Medicaid or uninsured, is going to stay the same rate. I believe the hospitals are probably going to have a greater payer source than what they have now. Our problem is that October 2020, in our current population, we estimate that 20% of our current patients are going to have Medicaid. That's not counting all the new patients that will have Medicaid and looking for a provider. So I don't think we're going to even have capacity by October of 2020 to see all the new Medicaid patients that are going to need to be seen. And so that is going to be an issue at the end of next year, is patients who now have insurance with Medicaid are not going to be able to find a doctor who can see them in a timely manner. Yep. And there's not many doctors that are accepting Medicaid to begin with. It's the infrastructure, it's the primary care world, and this is not a Lincoln problem, this is not a Nebraska problem. This is a problem throughout the country. There's just not enough primary care providers to care for all the people that that need to see a doctor. So there's things going on. We're trying to be more creative. We're trying to figure out how to make it so patients don't have to come in and see a doctor. You know, that's why telehealth is such a big deal right now. Phone a doc. There are things that organizations can do that keep the patients from coming to see you unless they really need to come see you, but all that takes money. You know, it's easy for companies like CHI and Brian to spend $2 million on an app so their patients can see them. Where our patients who could benefit the most, we don't have $2 million to develop an app so that patients don't have to come in. I would say 25 to 40% of our patients that are seen every day really do not need to be in the doctor's office. Dr. Israel, our CMO, may disagree, but we have so many sniffles, so many things that could be done over the phone. You know, having a triage, having an RN triage that patient, have standing orders to write certain prescriptions based off the symptoms. A lot of patients are still asking for antibiotics. Our organization is very conservative with pain meds and antibiotics. And a lot of our reviews on Google and Facebook are showing that, because we just don't hand out antibiotics and pain meds as willy-nilly as you know, we used to. And so if we can keep people at work, if we can keep them at home and just have like a phone-a-doc or a telehealth, that's what we're trying to build the infrastructure to support. That way just the patients who come and see us, or just the patients who really need to see us, are the ones coming in the door. So we have 3 dentists, 3 dental hygienists. And so I'm not really advocating you sending your dental patients to us because once again, we have more dental patients than we can possibly see. Our dental hygienists are booking out till March, which is very difficult when you have someone who has a very bad gum disease, where we tell them they got to come in every 3 months or every month just to get their gum disease seen in a timely manner, and we can't get them in because we don't have enough dental space. Luckily, we got a grant. We got a $300,000 grant from HRSA, and we are actually adding 2 more dental rooms to our dental clinic. So if you've been to our facility, by the end of the year, it's going to look a little bit different. There won't be a dental entrance. All patients will go through the medical side, and all patients will be registered there and then taken back to the dental. So we'll be adding 2 dental rooms. Here's our behavioral health consultants, Shay, Heather, and Brenda. Patient support, so we have staff that are dedicated to getting getting patients set up with the sliding fee discount program. They're at all the outreach events. They do the marketplace applications. And so when I say we really try hard to get resources for our patients, I mean, we really try hard. It's in our best interest, in our patients' best interest, to try to get them on some type of resource, if possible. And so the girls do a great job by doing that. We have a partnership with Legal Aid of Nebraska. So Legal Aid comes to our clinics on Thursdays, mornings and afternoons, and they help our patients out with resources that you're not going to find anywhere else. They'll help with divorces, they'll help generate wills, if you have patients who have traffic fines, they'll work to help them get their traffic fines reduced or dismissed. Patients who are having problems with Social Security, they won't be able to do a whole lot, but they can send them to the right people. But legal aid is a great value for our patients, and it's really a great partnership that we have with them. So one of the things I'm proud of is that we, because of the care that we've put into the organization and quality assurance, last year we exceeded our health outcomes. I was talking a little bit about value-based purchasing agreements with doctors. We have the same thing. In fact, we're part of the managed care organizations, the Medicaid managed care organizations. We have an accountable care contract with Blue Cross and other payers. So we are, plus our UDS, which is the Uniform Data System, because we receive the $1.5 million per year, we have to submit many reports to the federal government. And because of the work that we've been doing with our chronic disease patients, we were awarded the top tier Health Center Quality Leader Award for 2018, which means that we are in the top 20% of all FQHCs in the country. So actually Nebraska is ranked #1 in quality against all the other states. We have 7 FQHCs. We have about 102,000 patients among us, but we provide the best quality out of any state for our patients. Some of our patients get, when we've acquired these other practices, they get upset because we do ask some interesting questions, but we have to ask them because the federal government says we do have to ask them. But this is why we have to ask them, because the reports that the feds want from us, we have to give specific answers to. So I'm a little proud of that. So one of the good things most of the time about being an FQHC is that 51% of our board have to be patients of the center. They could be a medical patient, they could be a dental patient, or a behavioral health patient, but my bosses, 51% of them have to be patients of the organization. And that's because it's the patients who should be driving our growth and should be giving me my marching orders to help serve the patients. So it's a good thing, trying to recruit patients to a board. A lot of you guys work for organizations who have a board of directors. It's very difficult. Just imagine trying to find a client in your caseload that you would recommend to be a board member. On that note, if you have a patient of ours in your caseload that you think would be a good board member, let me know. I will buy you dinner. I will take you on a shopping trip to Kohl's, whatever it takes. We always need patients to be board members. So we do accept insurance. So I just signed a new contract last week. So we have 45 different insurance companies that we are credentialed through. So we accept all insurance, including Medicaid, Medicare, as well as our sliding fee. How many of you guys are familiar with Medica, the health insurance marketplace plan? So we are credentialed with Medica. However, the bronze tiers, unless they're platinum, some of you guys may know this, but the bronze tiers, they can't find local specialists. Those plans, those patients have to go to Omaha for most of their treatments, unless St. E's can do it. But luckily, Medica is going to have a rival next year in the marketplace. So those plans will be coming out, and so Medica will not be the only game in town, which is good, because competition is always good. Our mission, our staff hopefully can repeat our mission statement, but it's 13 words, and our goal is to be a trusted resource for excellent medical, dental, and behavioral health services. The 13 words are very important to me and our organization, and I often go around and ask our staff because that is what we're trying to do for all of our patients. I want to be the organization that our employees choose as their primary care provider. I want them to refer their family members to us as their provider. I want them to recruit their family and friends to come work for us. That's the type of organization that I want, and so I want all of our staff to know what our mission is so that everybody's on the same page. So here's our clinic locations. So our medical and dental clinic is on North 27th Street. We have the Health 360 Clinic, which is a partnership with Lutheran Family Services. That's at 2301. Thompson Clinic, which is in the Bryan West Medical Plaza. The Creswell Clinic, which is our newest one, at 3100 North 14th Street. And then administration's where my office is, our CFO, our billing, our call center folks, Jane, and we have patient support there too, so our CDE, health educator. Any other questions? Yes. Yeah, so we, as an FQHC, we have chosen to offer a voucher for people who are homeless or near homeless, and they are sponsored by a community partner or hospital. We will waive their co-pays for 90 days, I think, or something like that. So the goal, and then every 90 days they have to re-attest that they have zero income. That's also available for caregivers. So if a caregiver who is taking care of someone, no income, let's say they're taking care of a parent, and they self-attest that they have zero income, we will waive their co-pays every 90 days, and they can come in, and that includes lab fees. So their office visit plus lab fees, and some dental. And so the goal of that program is to get them back on their feet to where they can go back to work or do what they need to do. You know, some of the speculation is, oh, people are going to be taking advantage of it, you know. For the most part, I think the ones that are utilizing the program are the ones that need it the most, and are benefiting and going back to being a productive member of society. You're always going to have people that come through. We had one that tried doing that, even though she made $50,000 a year, come to find out. So we have some people that tried to scam the system, but for the most part, we believe that's very important to get those people back on their feet. Yeah, we don't do anything with medications because those are run by the pharmacies. We don't even have a fund specialized for the medications. But yeah, so we can't really do much for medications.
And where did they get the vouchers?
So what happens is that the patient, or the sponsoring agency will usually call and schedule the appointment with our staff, or the referring agency can send the voucher with the patient to our facility. We don't really recommend that because the voucher gets lost. We've even had people that have tried duplicating that voucher. And so we would just recommend that the partner agency contact our patient support at 476-1455 and then make an appointment with our patient support, because everybody's got to go through patient support, no matter if they have insurance or not, because we want to make sure everybody gets qualified for that sliding fee scale. And then patient will bring the voucher, or will hold on to the voucher at the day of their appointment. Discharge planners at the hospitals go through one of our RNs to get them appointments. We do have a lot of problems. In fact, our no-show rate is about 20% on average. With hospital-made appointments, it jumps up to about 50 to 60%. And so whenever hospital discharge planners call to make the appointments, in the past, most of those times the patients just no-show. So the nurses will take the information about the patient. We will contact them and see if they are really wanting to come to us. So most of the time, if they have a service point card, they're already set up with Matt Talbot or Centerpoint or the shelter or something like that. But the discharge planners will, if they will vouch for the patient when they call and talk to Rhiannon or Claire, then we'll take that into consideration. All right, thank you.